Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a cataract with small pupil. There is past history of repeated attacks of uveitis. There is a inflammatory membrane at the pupillary margin. I have taken up this case for surgery, and in this case I have decided to use iris hooks. By this time the main incision and a side port on the left side of the main incision has been made. An air bubble is injected. Beneath this air bubble, trypan blue dye is applied underneath the iris through the small opening so that there is uniform staining of the anterior capsule of the cataract. The dye is partly washed out because some more dye is still there behind the iris. Visco is injected. Since I have already decided to use iris hooks in this case, I am making some stab incisions. This is one at 12 o'clock and this is one at 7 o'clock and this is one at 9:30 o'clock and this is one at 4 o'clock. 4 stab incisions have been made. Now I am placing the iris hooks. This is one going through the 7 o'clock stab incision. The second iris hook goes through the 9:30 o'clock stab incisions. Stab incision and hooks the pupillary margin. At this time I am not retracting the iris much, just placing the hooks. Now this hook goes through the 12:30 o'clock side port and here it is. The iris sphincter has to be torn in this case to dilate the pupil, no other way. This one going through 4 o'clock side port. Now I am retracting the hooks. Now the size of the pupil appears little inadequate. The cataract is very hard and I need some more exposure of the anterior capsule. So I take one more hook, introduce it through the side port meant for chopper, and I find that this is not the right position to retract the iris. The iris has to be retracted little towards 3 o'clock. So I make another small stab incision at around 2 o'clock, very small one, and this through this small stab incision this iris hook is passed. And now the exposure is adequate. Some more visco, and now I'm going to do capsular axis with the help of this utrata forceps. This little jonular weakness, and here it is. I have to make adequate sized Rhexis. Lot of dye still there, wash it out, inject some more SPMC, and now try Rhexis again. Yes. In comparison to the size of the nucleus, this is a small Rhexis. Size of this Rhexis is about 4.5 millimeter. So it is going to be difficult to manage the nucleus because the size of the Rhexis is small. When the nucleus is hard and the Rhexis is small, one has to chop the nucleus into many smaller pieces. At least 6 smaller pieces. Better it should be 8 pieces. Did some more hydro. Because of jonular weakness, the nucleus is not rotating easily. So I take 2 instruments, 2 hooks, and bimanually rotate the nucleus. Yes, the nucleus is free now. And now is the time to introduce the tip of the phaco needle. And here goes the phaco needle with its bevel down. Gently glides over the iris. Some superficial lens matter is removed. Now I did some sculpting at the center of the nucleus because the cataract is very hard. I made a crater. If we make a crater, it becomes easier to chop the nucleus into many smaller pieces. And now I start making a small trench, hold the nucleus, and this is the first job. Rotate it 180 degree and divide the nucleus completely into 2 heminuclei. This is the first chop of this heminucleus. This is the second chop of this heminucleus. And this is the third chop of this heminucleus. So this heminucleus has been divided into 4 pieces. And now I start emulsifying the pieces. So when the Rhexis is small, if you make smaller pieces, you can manage the nucleus. This is the trick. This Rhexis is quite small, nucleus is quite hard, but since I made 4 pieces of this heminucleus, it has been managed easily. Now I come to the other heminucleus. This is the first chop on this heminucleus. This is the second chop. And this nuclear piece is emulsified. And this is another chop. And this heminucleus become 4 pieces and they get emulsified. Ultrasonic energy used is 85%, flow rate is 45, vacuum is 450 millimeter of mercury. Visco is injected to fill up the antechamber and the capsular bag. And now I use this 23 gauge Simcoe to gently remove the cortex. I'm keeping an eye on the jonule. If there is jonular dehiscence at any place, I must put a CTR, I know that. The side port is small. The Simcoe didn't go So I have to enlarge the side port a bit. Did that. And now I go through this side port and remove the cortex from 11 o'clock, 10 o'clock and 9 o'clock. Did some polishing of the posterior capsule. Fill up the antechamber and the capsular bag with visco. Enlarge the main wound a bit on the right side. And now implant an intraocular lens. Before implanting the intraocular lens, I remove the 12:30 o'clock iris hook. Otherwise, what can happen is the intraocular lens can press over the iris and there can be iridodialysis. So before implanting the intraocular lens, remove one iris hook, either the right side one or the left side one. The lens has gone in the capsular bag. And now I inject some visco, retract the iris hook, make a small nick there, and enlarge the Rhexis a little bit. This is to prevent capsular phimosis. If the Rhexis is very small, there is more chance of capsular phimosis. And now some more visco has been injected in the antechamber, and then the iris hooks are removed one by one. Look how it is removed. Retract the silicone guard, advance the hook, disengage the pupillary margin and remove it. Application of iris hook is not difficult. Learning curve is not steep. Anyone can use iris hooks in small people. In this case, there is significant amount of sphincter trauma, but to do the case, I had to sacrifice a part of iris sphincter. Go behind the intraocular lens, remove the visco which is between the posterior capsule and the intraocular lens. And now do some more irrigation and aspiration. In this case, it was almost impossible to use a B-hex pupil expansion device. Yes, I could do it, but I had to sacrifice the genular sphincter anyway. I had to stress the pupil and then use the B-hex pupil expansion device. And now this is the final lavage of the anterior chamber. The antechamber is formed very nicely. With the Simcoe, I pull the iris, holding it at the pupillary margin towards the center, and now you can see the areas of sphincter tears. I thought of removing the inflammatory membrane, which is we can see at the pupillary margin at 1 o'clock, but I thought of removing that, but then I thought that I can cause This is the some pigment, but this one I cannot remove. If I pull it vigorously, there can be iridodialysis. So I leave it there. Hydrate corneal stroma and close the side port nicely. The stem incisions through which the iris hook goes, they don't need any hydration. In this case, we made 5 stem incisions for 5 iris hooks, 1 stem incision for the chopper and the main incision. So 5 incisions in this case. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Friends, in some cases it becomes necessary to use iris hooks. You cannot think of Malyugin ring or BX pupil expansion device. So don't hesitate to cause trauma to iris sphincter and use iris hooks in such cases.